This is a video demonstration of arthroscopic decompression of central acetabular impingement using a Notchplasty technique. In this hip, you can see there is wear to the femoral head superomedially, an area that does not normally become worn by femoroacetabular impingement, nor from dysplasia. The ligamentum teres is similarly worn and damaged. This has occurred because of notch osteophyte, an osteophyte surrounding the acetabular fossa. In order to treat the underlying offending notch osteophyte, we use a burr to perform a notchplasty. This comprises a resection of the osteophyte surrounding the acetabular fossa. As we consider the effect of this notch osteophyte, it may impinge upon the ligamentum teres and the superomedial femoral cartilage in rotation, in flexion and extension, or in abduction and adduction. You can see a clear demarcation between the normal cartilage of the acetabulum and the area that is osteophyte. And as we remove the osteophyte, we reveal the normal underlying acetabular fossa. In this segment of the procedure, we're working primarily on the anterior part of the acetabular fossa. At present, the arthroscope is viewing through the anterolateral portal using a 70-degree arthroscope, and this is a 5mm burr being used through the anterior portal. It should be noted that a distal anterior portal or a mid-anterior portal may be disadvantageous for access to the acetabular notch, as it may come in at too much of an angle. Therefore, it is our recommendation to use a traditional anterior portal or a slightly modified, slightly lateralized anterior portal, but nonetheless a portal which is proximal to the height of the tip of the greater trochanter. This allows a more direct line of attack into the joint and therefore better access to the notch. You can see in this portion of the video that the notch osteophyte extends all the way down to the transverse acetabular ligament. The entirety of the osteophyte will be resected using the burr. The notchplasty is performed only after removal of the majority of the synovitis in the acetabular fossa, thus exposing the osteophyte. Invariably, in these cases, there is an extensive amount of synovitis in the acetabular fossa. At this point, we've switched the camera to view from the anterior portal, and the burr is now working from the anterolateral portal. This allows us access to the posterior parts of the acetabular notch and resection of the posterior osteophyte. The posterior osteophyte may come into play in internal rotation, whereas the anterior osteophyte may interact with the ligamentum teres more in external rotation. We've noted that these osteophytes are well correlated to damage to the ligamentum teres and to the superomedial femoral head cartilage. The osteophyte is undoubtedly a result of the arthritic process. However, once present, it may accelerate the arthritic process and be an independent source of pain. Thus, in the early arthritic joint, where the cartilage is otherwise well preserved, we have found notchplasty of the acetabular fossa to be a useful technique and a reliable technique in order to address this particular part of the early arthritic process and to address central impingement on the acetabular fossa.